In this video, we'll see how some inappropriate setting in a phaco machine can cause surge, which can cause some complications, and how these are being managed. Now, this is a phacoemulsification surgery. It was a pretty hard mature cataract, and it is happily we are chomping away the nucleus, which is bulky, occupying nearly most of the bag. And here we have half of the nucleus bisected and consumed using phaco power. Now, as we see, the last terminal part of the nucleus, when it is being consumed, there is significant surge which causes a PC tear. This is when it happens. Let's reverse it and see that again in slow motion. And we can see that this is the point where the PC tear occurs, and there is a small chunk of nucleus which goes inside. Now, what to do in such a situation? The first thing is not to withdraw your phaco handpiece, stop aspirating, keep the irrigation on, and fill up the chamber with viscoelastic, which will not allow shallowing of the anterior chamber when the probe is removed. Now we can see the PC rent usually will extend once we are coming out, and this is because vitreous is more or less like a conical shape with a broad base inside and the apex pointing out towards the wound, and this is why the PC tear will usually extend. But once the vitreous is being taken care of, you can appreciate that tear will appear smaller. It is because the tear is not extended, it is just being stretched due to the presence of vitreous. And once we cut off the vitreous which is prolapsing into the wound, we can see the PC tear now appears much smaller. And this is the correct way. This is how a vitrectomy should be done. First of all, dry vitrectomy once you have vitreous in control, then irrigation and simultaneously vitreous removal. Once adequate clearance of the vitreous has been done from the anterior chamber, we can proceed to implant the IOL. Now, I prefer to implant an IOL in such a situation in the sulcus, and for this I find that even single piece IOLs, they do the justified job, and I have not seen any complication in my cases. Although it is also recommended that 3-piece or multi-piece IOLs are a better choice for implanting into the sulcus. But when we look at other alternatives like phakic IOLs being implanted in the sulcus, I don't find there's any fear of shying away from these IOLs being implanted in the sulcus. Once the leading haptic is placed in the sulcus, then very carefully the optic and the trailing haptic is projected inside, and we can see the trailing haptic being placed inside the eye and being dialed into the position. It's very important to make sure that there is no vitreous extending from the rent towards the wound. That can be the cause of future complications including retinal detachment and endophthalmitis. Pilocarpine is to be injected to make sure that there is no vitreous strand. I prefer to dilute my pilocarpine to half the dilution, and this reduces the pain as experienced by the patients when this is being injected in the anterior chamber. I'll just remind that this whole of the surgery is being done under topical anesthesia, and we can see the pupil is nice and round. There is no remnant of cortex or nucleus. Just a small, very small chunk has fallen down to the vitreous cavity, which I plan to observe and see what happens next. Anterior chamber has been washed. It is being inflated. And usually the end result is that some amount of viscoelastic will always go through the PC rent and will be a contributing factor for increasing the intraocular pressure. Here we can see that. But post-op at the day 7, the cornea is clear and the vision is 6-9, and in the dilated state we can see the IOL is nicely centered and media are clear. Thank you.